Coming up, healthcare in America.
One of the things the Affordable Care Act did is I think it's changed the incentives. So going forward, won't happen overnight, but over the next decade, we're going to have a big change in how care is delivered.
University of Pennsylvania's Ezekiel Emanuel, one of the architects of Obamacare, delivers a passionate defense of the controversial act. It's just ahead on Global Ethics Forum.
Good evening. I'm James Traub, and welcome to Ethics Matter at the Carnegie Council. Our guest tonight is Ezekiel Emanuel, who is both an architect of and a leading authority on the Affordable Care Act, known as Obamacare. Ezekiel's resume is much too long for me to cite, but I'll just mention a few of the high points. He earned a PhD in political philosophy as well as an MD from Harvard. He's the author of a great many articles and books on healthcare and also on bioethics. He heads the Department of Medical Ethics and Health Policy at Penn. He served as special advisor on health policy to the head of the White House Office of Management and Budget. And he is the eldest member of the Flying Emanuel brothers. So thank you so much for being here tonight.
My pleasure. It's a great honor.
I want to first ask you a little bit about kind of what made you you. And so Ezekiel wrote a book called The Brothers Emanuel about these three famous brothers, himself, Ram, and Ari. And one of the things that struck me in reading it is that given the fact that the three of you were also extraordinarily successful, it seems to me the central message you got growing up was not succeed. It was do justice and maybe also read books. So could you talk a little bit just about how the life you led as a kid shaped the choices you made that have brought you to this place?
Our mother was very active, initially in the civil rights movement, dating from the 50s and early 60s, when it was pretty unusual for a middle-class white woman to be involved in the civil rights movement. We had a lot of meetings at our house on civil rights, and then subsequently through the decade became very active in the anti-war movement, again, well before it was fashionable, and was very active in democratic politics in Chicago. My father is a slightly different type of person in that his passions tend to be, he's a doctor, he cares for people, but he was very active in the lead paint removal days in the early 60s when lots of housing in major urban areas was filled with lead paint and a lot of kids were getting poisoned and were having tremendous difficulties. And he ran into this because he's a pediatric nephrologist and had to dialyze some of these kids. And so, you know, these kind of activities were sort of the bread and butter of sort of our daily life. You know,
and you were like a kind of baby Vietnam War protester and things like that?
Correct.
Because you were just a little, you were young to have been that, but this
right,
stuff
I
was...
did not, right. I escaped the draft by 1 year, or the lottery. But we were very early on, went to a lot of civil rights demonstrations, a lot of anti-war protests. I did a lot of campaigning in the 1968 election for Gene McCarthy, especially in Wisconsin.
And you were
pivotal
11.
primary.
You were 11 at the time, right?
Correct. This is what we did. It's like we didn't think, you know, you need a comparison class, and we didn't really have a comparison class. That's just how we grew up. And so political discussion was very, very just what the table was about.
So it sounds like being a doctor with the kind of concerns you have was a highly over-determined thing.
Well, being a doctor was highly determined. You know, I'm the firstborn of a doctor who's an immigrant family, and you know, Jewish, and I'm also I was pretty good in science. So he's like, you know, well over-determined, but I also did not like and could not, it wasn't in my character to sort of be the doctor my dad was, which was to care for patients one at a time. That drove me, I would say, around the bend. Not because
what did
they
you
weren't.
Not like about caring for
No,
patients?
no, I love caring for patients, and I love my patients. It's just that you saw the same problems over and over again, and you were like, God, there's got to be a systematic solution to this problem. I can, you know, we got to do better than my just treating these patients over and over again. If we did something different, I'm sure they wouldn't come in all the time. And so that was a major driving force. And you know, one of the things which early on, I started my career working on end-of-life care because I saw how bad we were doing it, how many people were sending to the intensive care unit, how many people really should be at home with their families. And then I migrated to, you know, we could change the system, control costs a little better, do more with the money we're spending. I also have written on research and how we could do research better and protect people better and do it more efficiently and faster. So I think if there's one thing, it's how do you make this part of the American system, which is, after all, about $1 in every $6 in your wallet, work better and work better for the public, both better health, better drugs, cheaper.
So before I ask you about any of the substance of this giant thing you helped craft, could you explain, as briefly as possible, consistent with being coherent, how it is that the United States wound up with the extremely odd, extremely dysfunctional, extremely complicated system that we have and that nobody else on the planet has?
No.
Okay.
That can't be
so
brief.
Should I just go
well,
on?
I mean, the problem is you just can't be brief.
Okay.
So there are lots
you do it at the length you think is necessary. So.
There are lots of strands to this. So one of the important strands is that around the turn of the 20th century, 1910, medicine suddenly becomes much more effective than it's ever been. You have safe surgery because of anesthesia combined with antisepsis, combined with the fact that we can identify bacteria. So you have suddenly hospitals are effective. Doctors are effective. They can make diagnoses. We have the introduction of radiological techniques. The X-ray comes in 1895. So you get a blossoming of ability. Simultaneously, you get a change in training of doctors. They can't be quacks. Quacks there's a reason we call them quacks, or snake oil salesmen. They actually need to be trained. And so in 1910, we changed the training process in medical schools to make them university affiliated, in hospital training. And we actually reduced the number of doctors because they have to have college education, 4 years of training. And that becomes more important. Then after the war, the federal government begins pumping a lot of money into developing hospitals, into research at the NIH. Specialists become important. Insurance companies pay specialists more. And so you get this reinforcing effect. More hospitals, more research to do more, paying people who do these special things more. And then you get Medicare, which sort of puts it all on turbocharge because it pays a lot of money. And one of the things that happened with the passage of Medicare is they were worried that doctors and hospitals wouldn't take 65 years old and wouldn't take payment from the federal government. Hard to remember those days. And so one of the things the Johnson administration did is that they actually paid hospitals costs and money extra for their capital investment. So suddenly making a big capital investment, adding a wing, buying new equipment became profitable for hospitals. They could get more money from the federal government. So the hospitals exploded, getting doctors who could do all this technology. So you've got this mix of insurance paying more specialists, more hospitals, funded research, and it is all driving great advances, but a lot of high cost care. And truth be told, we have a very dysfunctional system. We are unique in how dysfunctional our system is, but I think it's fair to say you go to lots of countries. I just returned from Switzerland. Plenty of dysfunction in Switzerland.
In Switzerland?
In Switzerland.
Are you
I know.
Sure?
I'm positive. So Switzerland is a country of 8 million people. They have 26 cantons. Everything's organized at the canton level. So you take 8 million people, divide it by 26. And then they have 100 insurance companies for just 8 million people. They can't streamline things. They can't. Every doctor is entitled to be paid. You can't say, well, you're not up to snuff, or we want to have good coordination between doctors and hospitals. Their hospitals haven't gone through a little more rationalization. So in a little place like Geneva, 500,000 people, they have public hospital, forget the private hospitals, 2,000 beds. I mean, just way out of proportion to need.
Is there also a kind of path dependence problem here, that somewhere way back in the past you do something or other, and that then sets you on a path which becomes crazily dysfunctional in a very different setting many years later?
Yeah, so as I was saying, we heavily emphasize hospitals. And so we end up with very expensive hospitals, expensive hospital care, and a lot of specialist care rather than primary care, which other places have emphasized. And it is path dependent. We have a way of paying, and it's hard you can't change that radically overnight. It's just very, very not difficult, it's impossible, really. So the best you can do is create a change of incentives and a change that'll evolve over time. And I think that's what the Affordable Care Act has tried to do.
When you were younger and had not had to deal with all the incredibly complicated issues that you have, did you think single-payer system, America can have a rational single-payer system?
I guess once I thought that. You get too close to thinking about the government running something for 300 million people, and I think you pause and you say, you know, that's probably not a good idea. Because if you look at Medicare, which runs it for about 50 million people, it's very slow to change, very hard to get real significant reform. If that was scaled up, you know, sixfold, it would be, you'd have real gridlock. One of the advantages of the American system is we can have a lot of experimentation and different trials on different scales and begin to see what works. It does create complications that makes it, you know, to some degree mind-numbing. On the other hand, it also prevents ossification that I think a single payer is more likely to have. My final point is, you know, I don't spend as much time thinking that through as many people would expect, in part because we're not going to have single payer in this country. I like to remind people who are big single payer advocates, and you know, I've been booed off the stage at the San Francisco JCC because I said, you know, just, we passed the Affordable Care Act by the skin of our teeth, okay, with no single payer element. There's no chance we would have been able to pass the Affordable Care Act with single payer element in it. Just not going to happen.
But it's still interesting to hear you say that, because of course it's a fantasy, but you're also saying even if you could imagine a different world where we could do it, it actually wouldn't be nearly as good a solution as the San Francisco JCC thinks it is.
Yeah, I think that's right. And I think part of the reason we think it's a good solution is it is a complicated system, and maybe it would simplify things, and it would simplify things, but you would also lose certain elements. And again, you know, I sit back and I cogitate, well, what's the organization that runs something really complicated and really well for 300 million people? And it's hard to think of any organization that does that. And that's what makes me sort of somewhat hesitant. And building up a big bureaucracy can make it just much harder to reform and modify. And I think, you know, again, we're going to be in a constant state of reform and modification for the next forever, really, in healthcare, certainly our lives.
Yeah. So let me ask you for a second about the politics of it before we go to the substance. So is your sense that the Republicans feared that this thing succeeding would be such a good thing for the Democrats and so catastrophic for the GOP that they had to oppose it at all costs, or they would oppose any piece of significant legislation as no different from anything else?
I'm not the political brother, and I genuinely don't know the answer to that. And I think you could say both motivations could be at play. I think the fact is we the Democrats, spent a lot of time, 9 months exactly, trying to get Republicans to agree. And so people who say, well, there was no negotiation, baloney. Max Baucus was empowered, negotiated, had the gang of 6, 3 Democrats, 3 Republicans, spent a lot of time all through the spring and summer. And I know, you know, my boss, Peter Orszag, was going to Olympia Snow, getting, here are the things she needs. All right, Zeke, I'll make sure this part's in it, you know, and other people working on his staff, make sure this part's, you know, we can satisfy her demands. And we did, we went to great lengths to satisfy her demands. And, you know, she was a Republican from Maine. In the committee, she voted for the bill. But when it got to the floor, lots of pressure on her, and she voted against the bill. So we spent a lot of time trying to get bipartisan support. There was just no movement on that, and I think it's unfortunate. I think there are things that could have, you know, Republicans care about that could have been in the bill that might have made parts of it better.
Just give an example or two of stuff that actually you think would have made the bill better that you couldn't put there because of this entrenched Republican opposition.
Well, I think one element was if they had come to the table and wanted malpractice reform, it probably would have been more politically feasible to put it in the bill. As it is, we did put more malpractice reform in than anyone's ever achieved at the federal level. And remember, one of the problems, which I think many doctors especially don't realize, is malpractice is not a federal issue. It's regulated at the states. So it becomes complicated how you put it in a federal piece of legislation. Nonetheless, there's some things we could have done more of on that kind of thing. Even now, you know, if you talk offline, away from the glaring lights and the publicity, you know, you talk to Republican staffers, Republican senators, you know, there are lots of things we agree with. And I keep telling my, you know, think tank colleagues down in Washington who, from more conservative think tank, you know, 70% of the things I want, you agree with. 70% of the things you want, I agree with. You know, among health policy experts, I think there's much less opposition, and we need some payment reform. We need a few other major changes, and everyone agrees. You know how I know that? A large part of the Obamacare structure, like the exchanges, like the individual mandate, came from Republicans. It's the
Like Mitt
idea that
Romney.
this isn't American. Well, it was American when the Republicans suggested it. Why, when the Democrats embraced it, did it stop becoming American? It really, it's a quintessentially American solution. We've got a market called the exchanges. You've got competing private plans. You've got the government subsidizing Americans who can't afford to buy in that market. Now, what's not American about that? Let me tell you how American it is. Richard Nixon, Jacob Javits, senator from this state, they proposed that in the 50s, okay? The only thing they didn't have in the 50s was a mandate. But that structure sure looked a hell of a lot like it was a Republican idea going way, way back. You got to think that this opposition is not about the substance of the bill. This opposition is more, as you might say, political, some elements they didn't like about it. But I think that if we weren't in such a partisan moment in American history, so polarized, this is the kind of thing which ought to have bipartisan overlap.
Let's talk a little bit about what's in the legislation. In terms of the way the Affordable Care Act increases access, obviously you have a whole bunch of big things that kids get covered up to the age of 26, not 18, Medicaid expansion, the exchanges and so forth. So given some of the problems, like states have refused to actually allow Medicaid to expand, how, in terms of access, how big is the improvement we have now and are going to have over whatever it was we had before?
So that states are refusing, I think, is a surprise to us. The deal in the Affordable Care Act for states is really sweet. Federal government picks up 100% of the fee, and it drops down to 90% of the Medicaid expansion towards the end of the decade. It's like, this is a great deal for you. So we didn't see that coming at all. I would say that I think all the states will be on board by 2020. One of the things most people don't realize is when Medicaid was passed in 1965, it took to 1982 for the last state, Arizona, to adopt Medicaid. So got to have a little.
Arizona's kind of a late adopter on a number of things, aren't
Got to
they?
have a little patience here. But I think they're going to come on largely because their hospitals want it, and they're going to figure out this deal of putting people, if we're not going to expand Medicaid directly, putting them into the exchanges with protections, I think is going to look appealing to conservatives. Notice how the exchanges become to look appealing to Republicans. And so I think you're going to have a lot of that. I think you're going to have a big blossoming of interest, especially because the deal is good. Once we get past the 2014 election and all the hullabaloo, I think the politics is going to die down on this. And so
you have said that you're an optimist, though.
Yeah.
Before the ACA was passed, there were, what, 50 million, 60 million uninsured Americans? Or
it's hard to calculate. And so it's 50 million uninsured residents in America. About 12 million of is undocumented. So citizens, it's 38 million. Those 12 million are not permitted in the exchange.
Right. So is it reasonable to hope that the 38 million is going to get pretty close to zero?
Won't get pretty close to zero.
What's a hopeful?
Well,
What's your
the
hope?
Congressional Budget Office says we'll get up to 94% coverage. I think that's conservative. I think we're more likely to get over 95%, and 96, 97%. Remember, if you take out that 12 million, that's about 3 percentage points.
So let's talk about cost control, because just as big a piece of this is America is bankrupting itself by spending $2 trillion a year.
No, $3 trillion.
$3 trillion a year, sorry.
Yeah.
So I recall in the early phases of the debate over the legislation, this sense of dismay that you were not able, that Obama wasn't really able to kind of attack this problem at its root, the fee-for-service thing. And so how much have you lost by not being able to do some of the things you hoped you'd be able to do at the outset?
Time will tell, and I'm not trying to be evasive. A major disappointment I have in the bill, again, as I point out, is we didn't do enough on cost control. And the main thing I would have wanted is a timeline for shifting off most payments off fee-for-service. Because now we have doctors and hospitals and other providers in two worlds. One world is we're paying you fee-for-service, which means, to make more money, you have to do more things, and you don't get paid if you don't do. And the other world is, we're going to give you a set amount of money in some form or another, and you're going to keep people healthy, and the difference between what we would have paid and what you're delivering the care for, that is a margin that we'll split or you'll get, or however it's very hard to negotiate. The incentive structures are different. Those two worlds are really incompatible, and we don't have enough of the second. When people say we got a sick care system, of course we've got a sick care system. We pay doctors to take care of sick people. They wait for people to get sick because they don't get paid to keep them healthy. If you pay them to keep them healthy, you will get a very different set of behaviors. And by the way, places that have worked under those different set of incentives do a much better job about keeping people healthy. So one of the problems I have with the Affordable Care Act is we didn't do enough to change those incentives. Nonetheless, I believe over time that change is going to come into place. Why? Well, if you look at the exchange, when people go into the exchange and compare, they tend to buy on premium and price, and they want a low price. How do you deliver a low price? Well, you can cut, but for the long term, the way you have to target people who are high-cost users, and you have to get in and reshape how you deliver care. And one of the ways of reshaping it is by changing how you're going to pay. So I see that as a long-term trend. Okay. Again, one of the things the Affordable Care Act did is I think it's changed the incentives. So going forward, won't happen overnight, but over the next decade, we're going to have a big change in how care is delivered, where care is delivered, and much more emphasis on efficiency, value, making sure that the care we deliver is really high quality and low cost. And there's lots of things we can do about that. Taking certain kinds of patients, instead of putting them into the hospital for treatment, putting them at home. They recover faster, you actually have higher quality care, and you save about 20% on a lot of those patients. Why should you go to the hospital to get your blood test? You're going to be able to go to Walgreens or CVS. They're going to have mini clinics. Someone just told me about there's a county west of Chicago that had a very low mammogram rate. So local hospital teamed up with a major department store in a mall, put in a mammogram unit right in the lingerie section. Rates went up, and women spent a lot more money at the store.
So on quality of care, you point out that for all the kind of crowing that politicians make about America having the greatest system so we can't touch it, the fact is on life expectancy, on infant mortality, and a whole range of issues, the United States ranks way, way down there. So what is it in this bill that should really make a person feel confident, or at least reasonably hopeful, that those things are now going to change?
So we have two specific provisions that are definitely going to improve, and already have to some degree improved things in the bill. And again, I think there is a sort of reinforcing mechanism. The two provisions are, one is about readmissions. So prior to the legislation, if you were a Medicare patient, you went into a hospital, you were discharged, your chance of being readmitted within 30 days was 20% roughly. Well, we had a penalty now put into the bill that if you didn't improve your readmission rate, 1% of your fees would, I was for, 1% just sounds like peanuts here. We need 10%. Well, it turns out 1% has had a big effect because since that penalty went in, you see the readmission rate going down, down, down. Now, not all of that is, great transformation of care. A lot of that is gimmickry, but it is forcing every place to really rethink how they're dealing with patients, and in particular, what we call the handoff from discharge of the hospital back to the primary care doctor, the calling of the patient, making sure they're actually taking their medications and things like that. That penalty has had a big effect, and I think it's going to improve not just the Medicare readmission, but everything. More importantly, we have a series of penalties related to hospital-acquired conditions, hospital infections, medication errors, falls, operating on the wrong part of the body, that are now going into effect. And we've seen since 2010...
Is operating on the wrong part of the body a widespread problem?
It's a problem that should be occurs 0 times,
one would
right?
think, yeah.
Right. So it's not 0.
Yeah, okay.
We want to get it down to 0. And I think, again, we've got a penalty element in that is going to do that. Similarly, we've put in other infrastructure elements like electronic health records that are going to incentivize doctors and hospitals to do better. Finally, I think one of the other elements is you're going to have, again, this reinforcing cycle. You go onto the exchange, you're looking for a cheap plan, but you want to be sure that the low-cost plan is also high quality. So you're going to demand quality assessments. In addition, big famous places are going to want to have quality assessments because they want to show they're giving high quality so that they can command a premium price for what they're doing. So Memorial Sloan Kettering, New York Hospital, are not the cheapest places in America, let's just put it that way. Well, their claim is we deliver better care, right? It is true we have a premium price, but there's a reason we have a premium price. All in, when you look at it, right, we do a better job of delivering the best cancer care. People don't come into the hospital with side effects. They live longer. That's going to be worth a premium if you can prove it. So I think there's now a big push to try to prove by each organization that they really have the best care going. And so I think you're going to have a lot of a push to both measure and improve your care. So I'm an optimist on that score too.
All right. Well, Zeke, thank you. That was a stupendous performance.
Thank you.
For more on this program and other Carnegie Ethics Studio productions, visit carnegiecouncil.org. There you can find video highlights, transcripts, audio recordings, and other multimedia resources on global ethics. This program is made possible by the Carnegie Ethics Studio and viewers like you.